Yes,
Great,
loud and clear.
great. So, welcome to today's webinar. International Childhood Cancer Day is commemorated on the 15th of this month of February every year. And we decided that today we just wanted to have something about childhood cancer awareness, focus on childhood cancers. And we're going to be hearing from both the clinical side and the civil society side. And we'll also be hearing from a parent of a child who is going through cancer treatment. So the theme for today is demonstrating impact from challenge to change. And I think we can just go ahead and get started. Let me just introduce myself. My name is Sydney Chahonyo. I am a childhood cancer survivor. I also work with Hope for Cancer Kids, and I also work with, I'm on the board of the Kenyan Network of Cancer Organizations. I'd just like to do a few shout outs. Number one, to the Ministry of Health for making this possible through the National Cancer Control Program. Secondly, to the team at Kenyatta National Hospital. Thirdly, to the team at KENCO, the Kenya Network of Cancer Organizations, who are co-sponsors of the event, and a special mention to Afron Oncology for Africa, which is an Italian NGO that is committed to the prevention and treatment of cancer in African countries. And they are the main sponsor for today's webinar. So thank you very much, Afron. So I think we can just go ahead and get started. And I want to introduce first Dr. Rose Munge to speak to us from the clinical side. Dr. Rose Munge is from Kenyatta University Teaching and Referral Hospital, and she's going to be talking to us about some of the gains, some of the impact that has been happening from her perspective as a clinician. So, Dr. Munge, please go ahead and share if you have any slides, or you can just speak. Over to you.
Uh, Thank you, Sydney. My name is Rose. I will share my slides. Just give me a minute. Are you able to see my slides?
Yes, we can see your slides. Maybe just put
All
them in
right.
presentation mode.
Which is this? Is that okay?
Perfect.
All right. Excellent. So my name is Rose Munge. I'm a pediatric hematologist oncologist from the Kenyatta University Teaching, Research and Referral Hospital. Thank you so much for this invitation to come and share the KU TRH experience. So it's a short presentation. I'll just go through what we've been doing as a hospital so far, and eagerly waiting to hear what the rest of the speakers are seeing and doing and how we can work more together. Yeah. So we're just going to go briefly through the background of what we're doing at QTRH and our experience, the wins that we've seen so far and the challenges, and of course to hopefully trigger discussion on what the way forward looks like. So the Kenyatta University Teaching, Research and Referral Hospital is a 650 bed capacity hospital that is based in Nairobi. It's a level 6 national referral hospital, has a wide range of specialized quality patient-centered care. One of the flagship projects of the hospital has been oncology. So the hospital started operations in 2019. At that time, it was mostly dealing with the COVID pandemic that was there. But once that was settled, then it settled in as one of the flagship, one of the priority areas for the hospital was oncology. So this started off almost immediately, and our adult pediatric oncology services is really quite big and robust and is actively growing and has been in place almost from the beginning. So on the pediatric aspect, what was there before was perhaps surgeries and radiotherapy, and a few patients were also given chemotherapy. But majority of the pediatric patients were sent to other facilities until the year 2023 through the last quarter. That is when the full pediatric oncology service started. So the service sees children and adolescents up to 17 years. And we have both inpatient and outpatient clinics, and also daycare services where the chemotherapy is given. Of course, all of this has been work in progress, starting with initially 1 or 2 patients in September of 2023, and the service has grown to about 150 patients so far. We offer chemotherapy, we give radiotherapy, and we give surgery, both neurosurgery, pediatric surgery, gen surgery, and orthopedic surgery as well. Majority of the patients that we see now are mostly seen through our daycare service, outpatient care and daycare services. We have an inpatient ward specifically for pediatrics. It has a 10-bed capacity, but we have plans of expansion to getting another 18 beds. So hopefully in the next 6 months to 1 year, we will have a bigger inpatient service. We see about 1 to 2 new patients per week. The patients, the types of patients that we see are mostly leukemias, but we also see Wilms tumor, we see a lot of brain tumors, and we see the bone tumors as well. So, of course, the first win is that we have established the service fully. Initially, there was no separated services for the pediatrics and the adult services. So the children were being admitted into the adult wards, the daycare services were being done in the adult outpatient spaces. But now we have fully been able to separate the two, so they are fully separate pediatric services. We're also quite excited that we have had partners to work with us. And I must I don't know how to say it, express a lot of gratitude to Faraja. Faraja and Gertrude's are the ones that have stood out for us with support. Gertrude's Foundation supports us with diagnostic support. So for some of the patients who cannot afford to get some of their diagnostics done in-house when we don't have those services, or if they need to take a sample outside, then Gertrude's Foundation has come in and given us a lot of diagnostic support. Faraja Cancer Trust stepped in for an urgent need that we had. We needed psychosocial support, we needed counseling services, we needed play therapy, and they have stepped in and supported us. They have a weekly day that they come play with the children, help us with psychosocial support, sometimes even with finances. They celebrate our wins with us. They have recently supported us to get a play area that is specific for pediatric oncology, and we are very grateful for that. We've had other partners who have come in, different companies who have supported us with toys, who have given financial support to the patient, who have given blood donations, all of which are crucial for the children who are dealing with these conditions. I'm happy to say that the unit is 360. The hospital is supporting our psychosocial support, our palliative care services are also on board, our nutrition support where we get daily nutrition rounds and supportive care for nutrition. So the hospital is very supportive and looking forward to growing the service even more. Of course, there are other institutions. We are having ongoing talks with other institutions to support our training for our nurses, our medical officers, anything that will help us to grow our service. So as much as we are, so these are just some of the pictures. This is our playground as it was being installed. Our service, this is just an image of the unit. Yeah? So our challenges are similar to cancer programs in low and middle income countries. Okay? So one, of course, the financial cost to caregivers can be quite heavy. We use a lot of the national insurance services, so the SHA. However, sometimes that amount is not adequate or the patient has not yet onboarded onto SHA, and that always comes with challenges. We also see a lot of late presentation, patients who come quite late, quite sick. We have challenges with diagnostics, so it takes a while to get the full uh, diagnosis out, and it allows us for we also have the usual issues. Sometimes we have some drug stockouts. We have some limited treatment options. Of course, we don't offer bone marrow transplant, and so for some patients, by the time they're getting to us or when they have relapsed, then we don't have too many options in what we can offer them. As always, we have limited human resource. Currently, I am the only full-time pediatric oncologist at the hospital, with support coming in from other facilities. We need to have more pediatric oncology nurses. We need medical officers on the ground, nutritionists, physiotherapists. All of this, we need a lot more human resource, of course. So the challenges are similar to what we see in all lower and middle income countries. And so from my perspective, of course, the way forward means that we would need to explore the public and private partnerships to see how much more we can support each other, encourage and support training for nurses, for physiotherapists, for medical doctors. We need to engage all relevant parties, the government, to expand the amount of resources that the patients can access through SHA and other partners, getting in medications perhaps for free to reduce the pressure on the patients. And of course, the more we can have research opportunities and tailored care so that we can target our patients more would be excellent. And so I think I'm going to stop there. One last thing perhaps is to say, as one of the wins, I forgot to put it there, is we are having our second bell ringing ceremony to signify completion of treatment for some children for us tomorrow in commemoration with the World Childhood Cancer Day. And for us, that is a great win because it's a show of how much work has been put into getting these children where they are. So I think I'm going to stop there and allow the rest of the presentation to continue. Thank you, Sydney.
Thank you very much, Dr. Munge. And it's great to see that KU is advancing in terms of, I know a couple of years ago, you didn't even have a pediatric oncology unit, and the children were just, taken to the relevant wards. But now that you actually have a unit that is up and running, that shows impact. That shows that there has been goodwill from the government. There has been resources that have been deployed, and at least we are reaching a space where you're starting to tackle some of these challenges. As much as there's still a lot to be done, we really commend you for the work that you're doing, and we appreciate everything you do for the children. To the doctors, all the doctors and clinicians out there, we see you and we appreciate you. Um, I'm going to just ask anyone who has any questions to just put them in the Q&A. We will take some questions after the second presenter, and then we'll take some more questions at the end. Our next presenter is meant to be Dr. Doreen Mutua, but I'm not seeing her from Gertrude's. So what we will do is we will skip and come back to her later. So I want to introduce David Makumi, Executive Director of Faraja Cancer Support Trust, who are working very closely with various hospitals, including KU, to ensure that on the civil society side, what you're doing as the hospitals and the institutions is being supported. So David Makumi, kindly go ahead and share your slides. And you're welcome to go ahead. David, we can see your slides, but I can't hear you yet.
Yes, thank you very much. I hope you can hear me.
Yes, now we can hear you.
You can hear me. Thank you very much for the opportunity. Mine will be very short on carrying the weight of civil society on behalf of the non-state actors who play a very big role in in advancing the childhood cancer agenda. Priest really humbled to have been invited to speak on behalf of all of us, various organizations around the country who play their part, however small, to advance the agenda, whatever areas that we have invested in as individuals and professionals and institutions to advance this important agenda and to change the narratives, the narrative around childhood cancer in our country and in the region. Yeah, and whenever I'm asked to speak about, the role of civil society in any setting, whether it's in childhood cancer, sometimes we in civil society do a lot, but we have not been able to tell our stories. So people only know the advocacy part, but I would be sharing with us that we do many, many other things, not just advocacy, civil society, men and women of goodwill, professionals in their own right, but who invest time, energy, and even resources to advance the agenda we have for childhood cancer, wherever that may be. And as I was introduced from Faraja Cancer Support Trust, I'm sure some of you know that we are present here in Nairobi, working closely with the Kenyatta National Hospital, also working at KU, as Dr. Munge has alluded with some of the work we are doing there, but we are also working in MTRH, Eldoret, so participants from Eldoret. So we're also working in Eldoret, and in fact, the lower picture is taken from the Shoot for Africa Hospital in Eldoret, MTRH. But we're also exploring opportunities in the counties, because indeed that is where the real needs are, whether it is navigation, psychosocial support, engaging patients and helping them through the system. So we are also looking at opportunities that would come our way. I'm sure some of you may have seen from social media. We are also more likely going to land in Coast General. So again, that is information that is out there in the public domain, looking at how we will be able to support kids in that region. But in the broader context, all of us know and glad that we have a multidisciplinary team today. The cancer care that we have, oncology care, excels and does a very good job in targeting the disease. Our doctors in the various national referral hospitals, in the private hospitals, the Gertrudes, the Kijabes, the KU, KNH, wherever that may be, whether it is Jaramogi Oginga Hospital, all of us, and especially clinical people, we are able to target the disease and do a good job of it with the advances that are there, targeted therapies, immunotherapies, and very, very advanced treatments. Then in radiotherapy, stereotactic radiotherapy, all those, they do a very good job. But what the healthcare system tends to struggle with is to care for the whole person with the disease. And that is where we, as civil society organizations around the country, come in to look at the whole person, not just a child with nephroblastima, or a child or a young adult with leukemia, but the entire ecosystem around the patient. What it is that they need, apart from getting their disease treated. Who are they? Were they students before they became patients? Maybe they were in college. Maybe they have just started school. Maybe they're in grade 1 or whatever grade it is in the CBC system. And maybe they are little kids dreaming of becoming doctors and engineers and so on. So, or maybe they were artists. They would like to advance that. So we try to complement this to ensure that we are looking at the entire ecosystem around the patient, the emotional needs, even on the emotional needs of their parents, the parents of these kids. Whereas the child may have very good outcomes from treatment of, say, nephroblastima, but what kind of trauma has the parent gone through, the family, the siblings, the classmates, if they were already in school, and even the villagers, neighbors. All that is an aspect that, our system tends to struggle. I'm not saying it doesn't do, but tends to struggle to think that those things are important. And that is where civil society organizations like Hope for Cancer Kids, Faraja, many others are doing a good job in the counties, coming to support, to listen to the parents, to occupy them, even during the long periods of hospitalization. Some of the kids are sometimes in hospital for 2 months, and sometimes we tend to forget that they need to catch up with schoolwork, or occupy them suitably, so that their hospital time, they could actually learn a skill or two. And that is an area we've been working a great deal with the young adults, with the adolescents, and even their parents, teaching them crocheting, basics of crocheting, beadwork, stuff like that, that would make their stay in hospital, whereas it's difficult, but make it meaningful. But importantly, use those as therapeutic tools, so that if a child is painting, they can paint their emotions, they can express themselves through art, or if they have a garden where they can play in, they can just learn to be children again. So if we are going to win the war against childhood cancer, we must appreciate that civil society organizations matter in this. And I'll just summarize this very quickly, that what we do also matters, and we are important members of the multidisciplinary or interdisciplinary team in the war against childhood cancer. We may not necessarily sit in tumor boards all the time or every time. We may not be on the bench looking at the molecular side of things and the genomes, etc. But our role is so critical. One, in the area of policy and advocacy. We play a very huge role in elevating childhood cancer within the national and county health priorities. When the counties are making their health plans, even at national level, within either the universal health coverage, looking at social health insurance framework, all this whole thing about cancer financing. We had recently that the cover for SHA is going to 800,000. Where does childhood cancer fit in all this? So it's important that we continue ensuring that our voices are heard, and it is the non-state actors, organizations, that would play a role in shaping policy nationally and even regionally within the East African Community region, and even globally, making sure that the voices of the low and middle income countries are heard, and not only heard, but heard and acted on. The other role I see us playing as civil society organizations is around awareness and early diagnosis. I mean, we all talk about the late diagnosis. A lot of kids maybe present to us very early, and sometimes it's not the fault of the parents. It may well be that this child was taken to a little dispensary somewhere far away, and they were being treated for everything else except nobody was thinking about cancer. So creating awareness is a role we play, because we work in the communities. We are more tuned to community work. We engage communities, and we can play a role in reducing stigma, promoting timely care-seeking behavior, and working closely with community health promoters, the CHPs. But we need to equip them with the knowledge and the skills around childhood cancer, so that they can help with the navigation of navigating kids, so that they don't waste a lot of time in the periphery. They should be sent to Dr. Munge and others in the national referral, whether it is in Eldoret. Send them straight there, so that they are taken care of in good time. So creating awareness is an important role, and that part of what we are doing this afternoon is actually creating awareness to a large pool of participants from around the country and beyond, also participants from the neighboring countries. So that's an important thing. But we shouldn't wait to do this only during, the Childhood Cancer Awareness Month in September or the International Childhood Cancer Day in February. We should do this all the time, every time, so that even if it means having a scheduled webinar or something every month around an area, an aspect of childhood cancer, we need to do it. Otherwise, somebody will think it's no longer a problem. Resource mobilization, again, is an important role for us who are non-state actors. Financing gaps. SHA tends to run out a great deal. All of us know that patients who say their SHA has run out within 3 months of treatment, they are told to wait for the next financial year. We know the challenges that are there, and we play a little role to try and bridge this gap for medicines, for diagnostics. We know medicines keep running out of stock. Diagnostics are a big issue. Indirect costs like transport of food and accommodation, something I know in terms of transport, accommodation, a number of organizations, including Hope and Courage International, Hope for Cancer Kids, all those organizations are doing a good job. Tumaini, all those ones that are providing accommodation to help alleviate the indirect costs. Faraja does try to support some of the patients, financially to bridge the gap, especially those who may be in the middle of treatment and they are stuck, and we try to come in, or those who are unable to support the treatment. So all of us have a role to play. But we do this by looking for resources from men and women of goodwill in this country, from corporates, literally, so that we raise enough money to be able to support whichever aspect your organization is playing. And we do play our part, within the larger context of CSOs in doing this, supporting a garden like the one that we've done in KU. All those things are things that are important, but may not have an allocation from the Treasury, and the civil society organizations would come in to provide accommodation, to provide food, and so on. The other area that civil society organizations here present, and those who are not even in this webinar play, is to strengthen the referral pathways, to engage health workers in the periphery so that kids are not unduly delayed, supporting also health worker training and supporting trainings, like I mentioned earlier, trainings for community health promoters. We do play an important role in capacity building, and especially in the aspect of psychosocial support. Presenting capacity building is very, very wide. And somebody will say, oh, we are making kids do the art and craft. Where is the evidence? In these days of evidence-based practice, we have a lot of evidence. Unfortunately, from out there, we need to generate our own local evidence that these interventions are important to the kids. They do have a big influence on the mental health of the mothers. So generating evidence that this is actually something we need to invest in is important, so that we have all-round capacity built for whether it's for clinicians and other support systems. And psychosocial support, providing family-centered counseling, or past these days, we're also talking a great deal about person-centered care. As I mentioned earlier, addressing everything around the patient's ecosystem, parents, siblings, everybody around them with the needs that are tailored and targeted to them, and helping them navigate the questions that they may have. Questions around SHA, questions around disease, questions around prognosis and outcomes, and even long-term survivorship. What will happen to my child after they finish the treatment? Will they be, grow up to play a role in nation building? So all those things are important. But again, things like peer support and survivorship care, that's an area that we need beefing up or boosting, and civil society organizations involved in this is critically important to pair up families or even kids, bring them together in a support group. We run a parent support group in Kenyatta from time to time, get them together so that they can share, and even the kids, so that they can share and feel they are not on their own, but also concerns around long-term survivorship and how do we address that. And of course, that has to be very targeted and intentional, because the work we are doing with the kids, say they are 9-year-old or 10-year-old or 8-year-old, is not the same work you'd do with teenagers or preteens who are 16, 17, who are 19. Sometimes there is always confusion. Are they kids? Are they adults? Are they in between? Are they young adults? And the interventions from a psychosocial perspective for them is very, very different, and we need to tailor this. We as civil society organizations are ready to play our part. So essentially, I don't have like 1,000 slides, which is, I'm sure, good news. I only have a couple of pictures, which are part of my favorite, because we are civil society organizations. Sometimes we also play, forget that we have a role to play even in prevention in childhood, in the context of childhood cancer. For some of these things, like infectious agents, and getting them, I think these days the kids get vaccinated against hepatitis B and C, but all those are things that will impact their health in the future, and getting our girls vaccinated against HPV for their future may not be for today, but we need to play a part, because we are in the low and middle income countries, and infections and infectious agents are a big problem. So if I may give, I think the theme of today's webinar is around impact beyond, from challenges to change. And I just want to humbly use this as a case study. And this is just this past year at Faraja. The numbers above the blue line are really for adult populations who also we serve. I'll not dwell on that this afternoon, but just mention in terms of keeping numbers, and the urge organizations present here, let's really generate data and local evidence. We have about more than 1,000 therapy encounters with the kids. That means, every week we are doing some different therapies, different programs, whether it is the beadwork or art, etc. So we had that between KNH, MTRH, and KU. So that's just on one aspect of encounter with the kids in terms of therapy and some of the other activities that ultimately we hope can even empower people, patients and their families with the skills to for generating income, things like knitting, crocheting, and this population of patients are making wonderful products that, if they are empowered in future, they could actually become income generating. They made more than 1,000 handmade items, and we at Faraja spent nearly 20 million just on supporting treatment, not just for kids but also adults. So like more than 200 patients were supported. Among them, some of them are children who have cancer. So we spent nearly 20 million doing that, not just for kids, but all the population. So we can all do something, create better tomorrows for the kids, create better tomorrows together as civil society organizations. There's so much we can do to brighten the future, and not just looking at survival as the only endpoint. Is an important endpoint in any form of treatment, but quality of life is equally important as an endpoint of treatment. And if somebody wanted to ask Faraja, where do you get your money? We don't get the money from Treasury, we get money from events. And I would like to invite all of you to be part of the events that we do. Our walk in September, this year it's going to be on the 26th, and whitewater rafting somewhere in Sagana. The details are on our website, whitewater rafting, just to be able to do what we do as civil society organizations. I do appreciate that many different organizations do different things to fundraise. So fundraising is almost is a part of all of us whether it's Hope and for Cancer Kids, whether it's Hope and Courage International, Tumaini, all those organizations doing wonderful work. They do that because all of you support us. So, ladies and gentlemen, thank you very much for the opportunity.
Thank you very much, David. I'm already seeing a lot of common interests. For example, we heard from Dr. Munge about the financial toxicity that families face, about drug stockouts, about late presentation, about limited options such as the bone marrow transplants, and then she mentioned a 360-degree approach. And then you come in on the civil society side, speaking about all the things you do from policy and advocacy, awareness and early detection, diagnosis, resource mobilization, capacity building, and psychosocial support. And it only goes to show that we need to work together, because as much as the clinicians and the medical fraternity are working on the medical side, there are certain things like psychosocial support, some of these out-of-pocket expenses you have mentioned, capacity building, that they might not have the resources or the know-how to implement. So it is good to know that we are working together, and I know Faraja is working with various public and private institutions to be able to see how to bridge that gap. So I think now we can move on to our next presenter. We have heard from the public sector, we have heard from civil society. I just want to invite somebody from the private sector, Dr. Doreen Mutua, a pediatric hematologist and oncologist from Gertrude's Children's Research Hospital, to kind of give us their take on things from the private side. In as much as they are private, they are working with the hospitals like KU to be able to ensure that some of these gaps are taken care of. So Dr. Doreen Mutua, the floor is yours. You can unmute and share your slides and take us through your presentation.
Okay, thank you very much to the organizers, Dr. Joy Frieda, Sydney from Hope for Cancer Kids, and everyone else on the panel. Thank you very much for inviting me to speak on this important occasion. Please allow me to share my slides. I'm doing that. Can you hear me?
Yes, we can hear you and we can see the slides.
All right, wonderful. So it was refreshing to hear how much we have made such tremendous progress, both from the public sector and represented by Dr. Rose Munge, and what is happening at the Kenyatta University Teaching and Research Hospital, Referral and Research Hospital, and also to see what civil society is doing, and really excited to see that we are embracing what we must have, and this is really collaboration. And this collaboration must come from all stakeholders if we are really to win the battle for our children with cancer. So I'm here representing Gertrude's Children's Hospital, and really to also share our story, because we have had our fair share of challenges and the change, but just to also appreciate that we've come from a long ways, and we are making progress and a lot of strides in improving the lives of children with cancer. So I know this may have been presented, but just to lay ground, is that we say that we have 3,300 new childhood cancer cases every year in Kenya. And this is really an underestimate, because we feel we probably should be seeing about 6,000 to 7,000 children per year. Unfortunately, this has been orchestrated because of poor cancer registries and unavailability of accurate data to be able to guide us to really know what are we treating and where we, but this is a challenge also that I know we are addressing aggressively, even with the National Cancer Institute, to strengthen the National Cancer Registry so that we may have accurate data on our patients. So this is the story of children with cancer in Kenya, and I know it's not a new thing, that more than 50% of our children go undetected or misdiagnosed, and up to 70 to 80% of the children who are diagnosed tend to come in with advanced disease. That story is not only unique to public hospitals, it's also very common in our hospitals, even in private sector. And as a result, when we look at Kenya, amongst the low and medium income countries, we are still saying that our survival rates are less than 20%. And this is compared to high income countries where most children with cancer will actually survive their diagnosis. So the question is it that Kenyan children cannot beat this disease? Is it that Kenyan children are different? Or what is it that is making us that our children are dying from a disease that in high-income countries they have managed to cure? And what do we need to do so that we can be able to save more lives? So definitely there are a lot of gaps, and I've heard this even from my fellow panelists, like that a lot of our children are coming in very late. And this is because most of our healthcare providers and also guardians have very low level of awareness about childhood cancer symptoms and signs. And unfortunately, most of childhood cancer tends to present with very general symptoms. That will be symptoms that reflect other common childhood illnesses. And childhood cancer, yes, we may be speaking about it, but it's actually a very rare disease. So if you don't have a high index of suspicion, then you are likely to end up missing a lot of the children. And that's the situation we're seeing even in Kenya. Weak referral systems where patients have to move in from one hospital to the other, even before they can even be told that this is the diagnosis that we're thinking about. And generally, I know there has been a lot of progress looking from where we have been several years down the line, that we didn't have a lot of hospitals that could really diagnose or even be able to treat children with cancer. And how about the cultural beliefs that cancer is actually equal to death? That most of the time when you get a diagnosis of cancer, then you really don't want to explore treatment. And this is the hope that we raise, even in such meetings and in avenues and platforms where we stand, is that childhood cancer can be cured. But the cure is dependent on early diagnosis and detection. And then for us who are in the healthcare system to make sure that we iron out and make sure that we have proper diagnostics and proper treatment that is holistic for our patients. And to be able to do that, the big elephant in the room is always financial constraints. Patients and their families really struggle to get even simple diagnostics on the table. And remember, you cannot treat cancer if you cannot diagnose it. So diagnostic challenges are real. And you've heard from even our other panelists that this is really a big challenge. Then even when a diagnosis is made, another elephant comes in that we have big treatment costs, and most of them have to be borne by the families that we are treating. So how are we going to be able to address this gap? And one of them is actually raising awareness that really childhood cancer does exist, but also wearing a different hat that is called advocacy, where whichever platform we are given, we are advocating for our children to have better access to diagnostic and even treatment. Then looking at our health-seeking habits and encouraging caregivers to, when their child doesn't get better, that they don't sit back, that they don't look for alternative sources of treatment, that they come earlier to the health system because an early diagnosis is equal to cure. Strengthening our referral system, and I know we are doing a lot of work in terms of trying to avoid that time wastage, that patients have to move from one facility to the other. And then training our staff so that they are able to diagnose and treat childhood cancer. And once they get to us is really to make sure that we also use evidence-based protocols. And now for sure, we don't have any reason because there are protocols for every setting, depending on what resources you have available. So these early warning signs and symptoms is very critical for us to get our children as early as possible into the health system. And because we really emphasize that childhood cancer screening is of very limited value. And if you invest in screening for cancer in children, then you'll end up losing a lot of resources and you might not be able to pick the children who really need that care. So early detection is key. It improves survivorship. It makes sure that we use less treatment. That means less side effects for our children. And later on also reduces also the costs for our families and even for our health systems, and reduces the toxicity that we see in our patients. So as a result of that, we have been champions as a hospital for early childhood diagnosis. And that meant that we had to move out of our small cocoon and go out and look for our partners, the Ministry of Health and Childhood Cancer Trust. And we designed a program where we were teaching frontline healthcare workers how to be able to diagnose or suspect. Sometimes we want you only to suspect and refer, or sometimes suspect and go on to establish the diagnosis if you do have the facility. And so to be able to do that, we designed some brochures, we did some in-person trainings all the way until when COVID hit. And now we had to rethink our strategy because, as you know, COVID came in that we couldn't have in-person meetings, and so we couldn't really travel out. So we reached out to our partners once in the IT world, and they actually did design for us an online module that you can actually go through and be able to see what are these things that I, as a healthcare worker, frontline healthcare worker, should be looking out for to be able to diagnose childhood cancer. This was also the start of a different journey for us. And this meant that we have to start looking for every avenue to be able to raise awareness. And it is in this year, in 2021, that we actually had our first childhood cancer walk. And this, we said, it's by the children, for the children. So we reached out to our families, parents, anyone who would listen to us, and we had our first childhood cancer walk to not only raise awareness, but also raise resources, because we said one of the things that is a big challenge is the financial constraints. So as we buy that t-shirt, we were able to actually consolidate that money, and some of the well-wishers also donated some money. And this is what our foundation uses to sponsor some of the children who are very, very needy from very remote areas, that we see even some on our telemedicine platforms, so that we may be able to have them access care at our facility. So the childhood cancer journey, if anyone has been on it or worked with patients who are on it, is actually a very difficult journey. It feels like crossing a bridge that has a river, and you're being warned that there are some crocodiles down there, that wherever you have to go, you have to be careful. It has to be very well calculated. Your moves have to be well timed, that you have to walk in synchrony with many, many other people. It might be one day with the counselor, another day with the oncologist, another day with the psychosocial team, another day with the pharmacist. But if we actually make it through this cancer journey, we can look back and see how much we've been able to achieve. And we are here to tell the story that we have had many challenges, many crocodiles, but if we keep pushing, if we keep moving together as a team, we will look back one day and see how much we've been able to achieve. So these are some of the childhood cancer cases that we have treated over a span of 5 years. And I know this is not the most recent data. We have more updated data, but we can tell you that we still have a lot of our patients being treated for acute lymphoblastic leukemia. We still have acute myeloid leukemia, and still a lot of the lymphomas and the kidney tumors we call Wilms tumor. So quickly in 2019, as I came back from my visit, from my training as an oncologist, one of the things that was a huge challenge and a thing that was really stuck in my heart is that children need to be home unless there is something that warrants them to be in the hospital. So this led to us thinking, how can we have a daycare unit where our patients come in, we give them chemotherapy, and actually go home? And because at that point it was going to be a new service, it was actually going to be something that that was not in the hospital. We were given a portion of the clinic to just develop and have a 2-bed daycare unit. And because of that, we just said for our children, whatever we have to do, let's take it and run with it. So we had it designed, put pretty colors, had a 2-bed daycare and a procedure room. So our patients would come in, have their chemotherapy given. If they just needed a vincristine, it is given and they go home. If they needed an intrathecal and that was all they needed, they have their intrathecal, the procedure, they're monitored, and after their procedure, they go home. This was actually a very positive move because this patient, I actually project them because this mother was one whose child, by the time they were getting a diagnosis that he had acute lymphoblastic leukemia, they had almost exhausted all their resources. And she came and she told me, you know what, Daktari, I'm not going anywhere, but I'm also not moving out of this hospital. So you have to look for a way of how I'll be able to stay in this hospital and still be able to get my child treated. So I said, okay, let us talk to the hospital administration and see if we can get a small daycare. So for a while, we would get treatment in the outpatient, but soon enough, our daycare was ready and we were able to actually have him go with almost 70 to 80% of his treatment given in the daycare, and they went home. This boy is now almost 7 years in survivorship and doing very well for us. So this was already a proof of concept that this is something we can be able to have our patients enjoy, that they don't have to be in hospital for them to actually get their treatment. And following that, we now have a new unit we call a Hope Center. This is one that the hospital has actually picked and made a whole ward was transformed to become our oncology center, or what we call the Hope Center. The Hope Center is actually a one-stop shop where you come in and you actually have your registration done. You come in, you have the triage, and after the triage, you are assessed by the medical doctor. Thereafter, the nurses then get ready to be able to pick and be able to give your chemotherapy either in the daycare, or if you require an admission, the admission is that the wards are actually in the same spot. We also have our pharmacy unit located in that one same area, so that if the patient needs to do anything, everything is done in that one space, and then they can actually be navigated to get out of the hospital. This is something that we are really proud of. It was something that we had really wanted as pediatric oncology specialists, that we have a dedicated hematology oncology center, and one that our patients really show that they deserve and they feel cared for and loved in this center. So this is how the unit looks like. And you can see we have our daycare beds, then we have our inpatient ward, and we have a nursing station. And also we do have our procedure room and a pharmacy and a place. And this is how the unit, a unit bed would look like. You have a bed and the inpatient is actually all self-contained, so that if they need isolation, they don't need to actually step out of their room. And remember, I always say the job description of a child is they must play. And a lot of the time where our unit is located is right outside where the hospital's main play area is. And we didn't want our children looking and saying, why is it that I cannot go out there and play? So this made that we have to create a small space for them to actually have a playground of their own, so that they don't have to interact with all the other hospital patients, but they have a decent place where they can enjoy some sun, enjoy some space, and enjoy a place where they can actually play. So this is actually one of the things that give me joy, even as I walk into that Hope Center. And coming soon is actually, we have had that we have a deficiency for our children who really require very highly specialized treatment. We have lacked in this region as a bone marrow transplant center. And this is one also that the hospitals has actually designed, and soon enough should be able to take off. And we can be able to increase the number of patients who should have access to bone marrow transplant services in the country. You can never do it alone. So you must work with a multidisciplinary team. I put this picture here because I was much younger. The smiles were big, but this was actually our humble beginning in 2018, that we have a multidisciplinary unit that meets and decides on the care of our patients. And truly, truly, this has been a game changer, because some of the complex cases that we deal with, you cannot be able to treat them without involving all the specialties. This was one of our most difficult cases in the multidisciplinary unit. This was a little girl we treated at the age of 2 years with bilateral Wilms tumor. And if anything can actually, if you were to be asked, this is one of the most complex cases to be treated. This child had tumor on both sides, and she required very calculated and meticulous care by the multidisciplinary team, all the oncologists, the surgeons, everybody, the nephrologists. And because of that multidisciplinary care and our surgical team, this child is now a survivor, going more into her fifth year of survivorship. Yes, she may have just a little bit of both kidneys, but this child is still here to tell the story that there is hope. This was our first Victory Bell celebration. And basically, I've heard that even at KUTRH, they're going to also be celebrating this. And this is a milestone. I promise you, most of these children, this is a day they look forward to, because they have fought the fight. They have actually won. And this is something that we are routinely also engraving in our practice, so that our children also have taken an opportunity to actually celebrate the great gains with their families. And this I bring to show you that when we rang that bell, this was a mother who printed all t-shirts for her family, counting every single minute, every single day, every single second her child had been treated for that acute lymphoblastic leukemia. But we celebrate with them, because we see, for us, it might be a journey we are walking, but there are people who are counting every single second that they are walking with us. So let's make that journey worthwhile. And we have several childhood cancer survivors. We have children who have had acute lymphoblastic leukemia, acute myeloid leukemia, Wilms tumor, solid tumors like muscle tumors, germ cell tumors, the lymphomas. We have many, many childhood cancer survivors. And we put it here because what I want us to take out of this is, yes, we can. We can make a difference. That statistic that Kenyan children do not survive childhood cancer is not true. They can. If they get an appropriate diagnosis and they actually get appropriate treatment, they can survive. Our foundation has been instrumental. As you heard, we have a telemedicine program that we actually run in some of the remote parts of Kenya. And we partner because some of the patients we see are actually from all over of Kenya. We've seen from Chemolingot, some of them we've seen from Masai, Narok, the interior of Narok. We've seen some of them all the way coming from Garissa. We've seen some of them from remote parts of Lamu. And these patients, through the help of our foundation and raising funds, either through our charity golf tournament or actually the childhood cancer walk, these children come in and they end up being treated for their disease through the foundation and with the support of partners. And we are happy to say that all these children, some of them were stage 4 Burkitt's lymphoma, and osteosarcoma, a child with Wilms tumor, are all survivors of childhood cancer. These children deserve care too. We also don't have only our children just going through treatment. We know whenever a family is going through cancer treatment, it affects everybody. It affects the parents. So what we do is that we bring our patients and we give them a support group where they can come, have a cup of tea that is provided by the hospital. They share their journeys, they share their stories, they share their struggles, one to another. They actually do that on their own. They don't need to have us there, but they're able to talk to each other, encourage each other, tell each other how do they manage to walk through the journey, and so that they can actually help each other, be each other's keeper. And we have even organized sometimes that these caregivers not only meet us in the hospital setup, we have taken them off to some places to do hikes. And as we do that, we get to learn more. We get to hear about their other children, how they struggle through their work commitments, how they had some very supportive bosses, how they were able to actually just even enjoy, but also to remind them that even their wellness is also very important to them. It also gives us an opportunity as healthcare workers to go out there and breathe some good air. So if you ever see a child fight cancer, it will change your life forever. Let us make this journey for our patients worthwhile. Whatever efforts we are making, let us keep walking. Let us keep running. We are doing something. We are moving from challenge to change. And soon we will have most of our patients with cancer survive their diagnosis. How can we do this? We have to train more. We have to mentor more. We have to work on our issues of blood, access to blood products, access to diagnostics. Keep advocating, whichever platform you're in. Make a difference. Say something. Don't keep your mouth shut. Look for partnership, both locally and internationally. Let me appreciate our nurses, our exceptional team of a multidisciplinary team, our foundation and partners, our hospital administration that has championed the changes that you're seeing, and the children and families who fight these battles, because without them, we cannot do this. Thank you very much.
Thank you, Dr. Doreen Mutua. That was a very moving presentation, and it also shows how, what is happening in the private sector. But at the end of the day, it's not about public or private or civil society. It is about the children, and you brought that out very well. I'd like to remind everyone, if you have any questions, to put them in the Q&A. We just have one or two more presentations, and then we can take all your questions. So also to the panelists, please kindly hang around because there are some questions that I can already see in the Q&A. So our last presenter is going to be a parent who is taking care of a child who has cancer. But before that happens, I just want to also speak from the civil society side, just to give my brief experience from the Hope for Cancer Kids perspective. So let me just go ahead and share my screen. I'm not sure if you can see my presentation. Can you all see my presentation? Nick,
Yes,
can you see my
Sydney, I
presentation?
can see. Yeah, I can see your presentation in slide show. It
Okay.
has the
Yes.
poster for today. Yeah.
Yes, exactly. Perfect. So I'm just going to take a few minutes to talk about what we're doing as Hope for Cancer Kids, because at the end of the day, we are here to demonstrate impact from challenge to change. We have heard from 3 other presenters. I'm going to present, then I'm going to invite a parent, one of our beneficiaries at Hope for Cancer Kids, to just speak about his journey. So I want to go back and appreciate AFRON, Oncology for Africa. As I said before, this is the main sponsor for today's webinar. Oncology for Africa was founded in May 2010 as an association committed to the prevention and treatment of cancer in African countries. In July 2010, the association was recognized as a nonprofit organization, and in 2013, they chose the acronym AFRON. AFRON are an Italian-based nonprofit organization, and they are committed to prevention and treatment of cancer in African countries. They have done some work in Mozambique, in Uganda, and I think in Rwanda. And now they are very keen in working in the Kenyan space to raise awareness both about childhood cancer and women cancer. So if you have breast and cervical and other cancers that affect women, they are also willing to partner. So thank you very much, Afron, for sponsoring this webinar. I will go straight into my presentation. As you all know, my name is Sydney Chahonyo. I am a cancer survivor, and I work with an organization called Hope for Cancer Kids. At Hope for Cancer Kids, our mission is timely and affordable cancer care for every child in Kenya. Our vision, ensuring care, knowledge, and resources for every child affected. Now, what do we do at Hope for Cancer Kids? we try to offer comprehensive support services. What we are trying to do is ensure that all these children have uninterrupted cancer treatment. There's early diagnosis and there's access to treatment. So our mission mainly goes around ensuring that all children in Kenya have access to timely and affordable cancer care. Some of the milestones, I will just go ahead and celebrate some of our milestones. Since 2015, we have covered over 10,000 monthly insurance premiums. This is through NHIF and through the Social Health Authority to a tune of over 5.5 million. And this is just paying for the insurance so that they are able to get treatment in public institutions. In 2024, our average number of children per month was 471 children we were providing with NHIF. With SHA, the numbers went slightly down, but they are on the way up. And we know that there are people who need these services. Next, we also look at out-of-pocket expenses. For example, transport and access. We have provided transport stipends directly to families to ensure that they can reach these institutions. There's no point paying for NHIF or SHA, and the child is stuck in Garissa and not able to get to Kenyatta National Hospital to get their treatment. So what we have started doing is paying for transport. Accommodation is also another big challenge that was identified, because when they come to Nairobi, what are they going to do? Where are they going to stay? What are they going to eat? If you're here for a 30-day radiotherapy cycle, they have nowhere to sleep except the hospital corridors. So we have now launched the One Hope House. I'll speak a little about it later, but we have launched an accommodation center in Langata to ensure that when these children come from very far and have nowhere to stay, we are trying to reduce the financial toxicity so they don't have to worry about where they're going to stay, what they're going to eat, and how they're going to get to and from the hospital on a daily basis. As I said, we want to ensure that these children have uninterrupted treatment. Aside from that, we also cover direct expenses, for example, blood work, medical tests, and essentials like diapers or care packages to families so that they stop worrying about the financial toxicity and they can focus on healing. Some of the wins for 2025 that I will share. That picture is of our art therapy classes at Kenyatta National Hospital, Ward 1E. So basically, our estimated survival rate as Hope for Cancer Kids for 2025 is over 60%. And I will talk about why that is important later. And this is also due to the power of combining medical treatment with comprehensive support services. This is the institutions working with the civil society organizations. We can't do it alone, but when we put our hands together, anything is possible. We have provided over 270 hours of art therapy. And this helps the children process their trauma through play. It gives them a reason to just something to look forward to, because some of these children are stuck in hospital for periods of 1 year, maybe even more than 1 year. And sometimes they don't even have their parents with them, like, for example, Ward 1E at Kenyatta National Hospital. So we give them a chance to be children. We give them a break from the battle, but we also help them meet some developmental milestones. Some of these children have never held a pencil. They don't know how to color. By the time they're done with our art therapy classes, they're able to write their name. They're able to color within the lines. And these are some of the things that, because they're out of school, separated from the community and their families, they have no other way of meeting these milestones except through programs like those that Faraja and Hope for Cancer Kids are providing. In 2025, we tracked about 147 patients just to see what is going on with them. And in our programs, the highest number of cancers in terms of childhood cancer, the most common was leukemia, with ALL being the most common at 19%. And basically what we're trying to do is we're trying to start getting data. Number one, to help build our programs. Secondly, to advocate for policy change. And thirdly, to be able to demonstrate impact so that we can be able to raise more funds to support these children. I've spoken about out-of-pocket support. We cover things like lab work, transport, food, urgent clinic fees. Sometimes it is even partnering with some of our donors to say this child needs a prosthetic limb or a prosthetic eye after retinoblastoma, and we're able to partner with certain institutions, certain individuals, certain corporates to be able to provide some of these interventions. Um, I talked about the 60% survival rate. Now, the Global Initiative for Childhood Cancer was started by the World Health Organization, and their main aim is to increase global survivorship to 60% by 2030. I know in some institutions in Kenya that is already true, but as a country, nationally, because of the lack of the lack of interconnectedness with the registries, with the hospital registries and the national registry. I know that we are in the process of strengthening our registries, but as a nation, it is still estimated to be 20 to 30%. So we are hoping that with some of these interventions, we can be able to increase the global childhood survival rate to over 60%, saving 1 million children globally. Some government interventions that have happened recently. I saw that the cancer centers in Garissa, Nakuru, and Mombasa signed SLAs with the national government to expand access to specialized oncology care. And this will also help to decongest referral hubs like KNH, MTRH, and KU. Because at the end of the day, if we have decentralized cancer care and if we have more comprehensive facilities outside of the main cities, then you'll be able to increase the catchment area, catch some of these cases earlier, and be able to treat them more effectively without putting too much strain on the system, on the national system. Aside from that, there are certain programs that I think we have been involved with locally and also internationally. I will, for example, include the St. Jude's Children's Research Hospital program called ICAYA. That is inclusion of children and young adults into the national cancer control strategies. And we actually had a team that registered and did a course. And we came up with various priorities and things that we needed to change, low-hanging fruits, medium-term goals, long-term goals. And I was part of that ministry-led team. And we actually came up with a framework which we are working on implementing. And now Kenya has also been asked to apply for a second cohort, which is in the process right now. And basically, what I'm trying to get at here is there are certain opportunities out there that will assist in healthcare system strengthening, in training, in capacity building, and this is both on the medical side and the civil society side. So we need to take advantage of partnerships, both locally and internationally, if you're ever going to make this difference. I spoke about our accommodation center. And as I said, we have launched an accommodation center it's in Langata. It's in Gay Phase 1. We're actually going to be having an official launch on the 27th, which is this coming Friday. If anyone is interested in joining, please reach out to Hope for Cancer Kids. I'll put our details in the next slide. But if you look on the picture on the right, that is something we had about 2 weeks ago. And we invited some of our caregivers and some of our beneficiaries, some of our survivors. And with the team from Afron, Oncology for Africa, we actually just had a party for them. We had some cake, we had some toys that were donated. We played with the children. And then we also had a debrief session with some of the caregivers. And all they wanted was a space to be able to speak, to be able to talk, to be able to share their challenges. And these are some of the things where the areas where civil society comes in very importantly. And I'd like to say that we have a capacity of 15 children and 15 caregivers. So if you have anyone coming to Nairobi and needs somewhere to stay, we get direct referrals from the major hospitals. So whether it's KU or Kenyatta National Hospital, you can reach out to us and we can be able to provide accommodation for these people. Our call to action: where you live should not determine if you live. If you want to get in touch with us, if you want to join us to make an impact, that's our number right there, and that's our email address, info@hopeforcancerkids.org, because every child deserves care and hope. Together we can achieve a 60% survival rate and beyond for all children. So that is the end of my presentation. I will stop sharing there. We are almost getting to the end. And before we finish, as I said, please put your questions in the Q&A. But before we finish, I just want to invite Peter Ngare, who is a father to a child who had cancer, to just give his story. And Peter, maybe you can just unmute yourself And I just want you to tell us a little bit about your story, give a brief description of the journey, speak about some of the challenges you faced, and some of the support you received that has enabled you to overcome these challenges. And just tell us a little bit about yourself and Koban. Go ahead, Peter.
Thank you so much, the organizer, to allow me to speak on this platform on personal of my son Korban. My name is Peter Angare. My son is called Korban Gabriel. Last year, our family
We can't hear you very well, Peter.
life changing news. Our son Korban
Is it just me or is he breaking up?
with cancer. That moment changed
Yes,
everything.
we are
He moved from
having
normal
difficulty. I think it's network.
family life into reality of hospital visit, lab tests, medications, and checkups. In the beginning,
Baba Koban, your network is not very clear. Are you able to move to a place that is a bit clearer? Can you hear me, Peter? Nelson, can you hear me?
Yes, I can hear you, Sydney.
Okay, I can't hear him.
Peter is facing a bit of I think it's a network issue. But Peter, you can try again.
hello, hello, do you
Yes,
hear
Peter.
me?
Yes, we can hear you, but a bit
Can you
faint.
hear me? Hello. No.
Un- Unfortunately, we can't hear you, Peter. Maybe as you try to fix your network, we can just go into the Q&A and take some of these questions. Just mute yourself and try to reconnect again while we take some of the questions. If I look into the Q&A, the first question I see, is there any support for refugee persons from cancer supporting partners? As Hope for Cancer Kids, we have not necessarily gotten that much referrals from refugees. I know there's one child we supported a couple of years ago from Burundi, but I know that the Social Health Authority and Social Health Insurance Fund is open to both internationals and refugees. So I know that if you register with your alien ID or your refugee ID, you should be able to register on SHA. And I know that then you can be able to get treatment in public facilities. I'm not sure if Faraja has anything on that. But one question that is for Faraja, how do you assist children and young adults receiving chemotherapy in private facilities? David, are you there?
Yes, yeah, thank you very much. Maybe the question on refugees. I know there is also an organization, the Hope and Courage International. I think the last time I visited their home, half of the patients they had were actually refugees from Burundi and other places. So But in terms of support, our center, Faraja in Eldoret, also has been in touch with the camps. We have had agencies that work with the refugees, like the International Rescue Committee and others in Kakuma and such places, reach out to us. We haven't worked a structured system yet with those agencies, but we have had a number of them reach out to us to help them help the patients navigate the system, and especially if they've been picked from it's tough enough to be in a refugee camp, and it's tough enough to have cancer at the same time. Yeah, but as you said, some of them are able to use their alien, but others are not even registered refugees. And for those who come to us, especially referred by a facility, for us, we just support whoever. And that brings me to the rest, to the other, that question about adolescents and young adults. For us, again, we do not have a problem with age, so we support whether it's pediatric population, young adults, and even adults, wherever regardless of the facility where they are being treated. So whether you are in a public hospital, or whether it's a mission hospital, or whether it is a private facility, we still support the patients. With the private facilities, I must add this rider is that we actually negotiate. It is contingent on the facility also willing to or accepting to also offer preferential pricing. I'm happy because a number of facilities are able to do that. Some of the private facilities are able to charge the patients supported by us as Faraja. They would not charge them the market rate. So if the facility is willing to also meet us halfway, then we are able to support. Where a facility is not willing to do that, that becomes a bit of a challenge, because they won't be able to offer preferential pricing, but they expect a charity to take the full load of for paying the treatment. That would not seem to us as fair, in which case, if that patient is being treated in a mission hospital, in a facility where the care is much more affordable, then it is actually easier for us. So regardless, we have supported patients in private facilities, but very often when they are also willing to meet us halfway.
Thank you, David. I'll pose the next question to our doctors, Dr. Rose Munge and Dr. Doreen Mutua. What are the most common childhood cancers in children? And secondly, what is your survivorship among children who have been treated at your facilities? Maybe Dr. Munge can go first, then Dr. Doreen Mutua.
Thank you, Sydney. Most common cancers we see the same trend in Kenya that we see worldwide. Acute lymphoblastic leukemia seems to be top of the list. Then the other cancers come in. Brain tumors are also pretty high, and then the kidney tumors. But leukemias seem to be on the top of that list. When the question about survivors, so for acute leukemia patients, we are just, remember we've been in operation about 2 years now, so we're just finishing our first lot of leukemia patients. So we should be getting out some data towards the end of the year about exactly how our survivorship is. But for the other cancers, the kidney tumors, the brain tumors, we've been seeing some, because I haven't analyzed the data properly, but we do have some patients who have completed treatment and they're still doing well. Some of them 1.5 years, going to 2 years post-treatment. So towards the end of the year, we plan to release some data, but given that the service is new, we don't have, we still don't have a lot of patients and data, but so far we can say we're getting some fairly decent outcomes. But the full numbers is a bit difficult for me to say right now. But for leukemias, we should be giving you answers by the end of this year.
Thank you.
Sydney, I beg to drop off because I had another engagement that is starting right now.
No
So
problem.
I thank you for hosting me, and we look forward to working with you. Thank you.
Thank you very much. Dr. Doreen Mutua, as you answer those questions, there's a question there about, are pediatric cancers generally inherited? Then after that, maybe you can talk to the most common cancers and your survival rates at your institution.
Okay, thank you for those wonderful questions. Most of childhood cancer is not inherited. That means we only see just about 5 to 10% of childhood cancer that is associated with a genetic syndrome. Some of these commoner syndromes would be like Down syndrome, that we see quite a bit in some of our patients. We also have other genetic syndromes that could look like with abnormalities like Fanconi anemia. Some of the kidney tumors and brain tumors and even the leukemias, they tend to also be in such patients. I know sometimes we also forget the inherited retinoblastoma. These are patients who have a defective retinoblastoma gene, and this is where they present with bilateral or both eyes having the tumor. And these are still cancer predisposing syndromes. But there are many, many others, the Wiedemann-Beckwith syndrome, a lot of other syndromes that we could also talk about. But most of childhood cancer has no risk factors. There is no genetic association. And so majority of the time, you're not even able to tell, why did this child get cancer? So that's a very important message, because most parents come in and say, what did I do wrong? And we say, there's nothing you did wrong. This is just something that happens. We ourselves don't know any risk factors to work with. Some children may need screening, and those are the ones with genetic syndromes, but outside of that, no. Now, in terms of what types of tumors we treat, acute lymphoblastic leukemia still tops up. Then we go to the lymphomas. We see quite a bit of Burkitt's lymphoma and the other Hodgkin's lymphomas. We also do have the renal tumors, what we call the Wilms tumors. For the solid tumors, especially something like Wilms tumor, we are at almost 90% survival rate. For the leukemias, we are looking into 60-70% survival rate. Again, I keep saying majority of the time what we need is really early diagnosis. And this is proof that if we really put our systems together, we can actually save many, many more children with cancer in Kenya. Thank you.
Thank you very much. I know we have run out of time, and I just wanted to find out if Peter is there to just give us in 2 minutes what your experience has been, the challenges. Hopefully we'll be able to hear you this time. Peter, are you there? Baba Koban, please unmute and try to say something.
Hello, Mr. Tidi, do you hear me? I'm here. Hello.
Yes, we can hear you.
Okay, thank you. Thank you so much, the organizer, to allow me to speak. I'm Pitangare, the father to Koban Gabriel. A brief description of my son Danny. Last year, my son was diagnosed of cancer. That moment changed everything. We moved from normal life into newly reality of hospital visit, lab test, medication, and weekly checkups. In the beginning, it was very overwhelming. There was fear of cancer. There was fear, uncertainty, and many unanswered questions. But today, I stand here grateful because Coban is doing well and responding to treatment. He continued to attend regular Monday checkups, and every visit reminds us the progress is possible. This journey has been transformed us not only as a parent, but as individuals who now deeply understand the challenges many families silently go through. The challenges has been emotional, financial, and logistical. In emotion, receiving this diagnosis was one of the hardest moments of our life. No parent is ever fully prepared to hear that their child has cancer. Financially, cancer treatment requires consistent consultation, medication, and laboratory tests. At times, access to care depends on the availability of funds. Logistically, regular hospital visits, long waiting hours, and coordinating treatment schedule can be physically and mentally exhausting. However, through these challenges, we discover resilience, faith, and strength we didn't know we had. Support that enable us to overcome. We are deeply grateful to the support that has carried us through this journey. First and foremost, thank the Almighty God for sustaining Coban and give us strength through this season. We sincerely appreciate Hope for Cancer for coming through to support us financially during critical moment. The assistant eased a heavy burden and allowed treatment to continue without interruption. Their support transformed uncertainty into hope. We also extend our gratitude to the doctors and the medical teams who have walked this journey with professionalism, dedication, and compassion. Their commitment to urban treatment and follow-up care has played a significant role in this progress because this combination support spiritually, financially, and medication and medically and medical, we have been able to move from crisis towards stability and hope. So challenges that are still need to be addressed. One of it is a financially support system for families undergo long-term treatment. If I can share in a nutshell, the way things started when I got the devastating news that my son was diagnosed of cancer. At that moment, I didn't have anything. If I can remember last year, I was having some financial constraint, and since that I'm a parent whom when after job I usually go home and I try to play with my kids. So that fateful day, I realized there's some things abnormal on my son. So when we took him to the local hospital, the doctor told us because his stomach was swelled, and on the right side his stomach was something very stiff. So the doctor told us that he has some stool blockage, and he gave us he prescribed to him a stool softener. But upon giving him that medication, it didn't change anything. So we were referred to Kenyatta. Then after going to Kenyatta, the doctor told us before they do any treatment for my son, we have to do CT scan on him. At that point, I didn't have any finance. I didn't have that fund to pay for the scan. So that's why I'm really stressing on financial support system, and even rather than financial, there's a thing of emotional and physical support for parents and the caregivers. Because when we got that news, even it was so much something that we didn't expect. I remember my wife was crying uncontrollably. Luckily, I was near the hospital, after she told me that the result is out and I should come to to get what is to get the news. I found her helpless in there, but I thank God that He gave me some strength to face the elephant in the room. I encouraged her that everything is going to be all right. So as far as that we are trying to look on financial support, even emotional. We should look on how to handle the cases whereby caregivers they've got that kind of a news we didn't even expect, and we know very well the kind of the story that goes around when somebody has been diagnosed of cancer, and the story that we usually hear about cancer. Nothing else is a coordinated support system where the organization, like the way I really commend the Hope for Cancer and the doctors who came through, because other than support us financially, the Hope for Cancer, they wanted to know each and every day they call, not even on a day basis, but in a weekly. They often call us and ask how our son is going on with the treatment, and in case of any support that we need from them, they usually be available, as well as doctors. They usually ask the progress of the boy, and that is something that it has given me a lot of hope and hoping for the better days. So for this, like the way I hear from doctor from Gil, who really st- stressed on financial support. I add on emotional and faster and coordinated support system after being diagnosed. When families receive early and structured support, the outcome improve not only medical, but emotionally and social as well. Our experience demonstrates that we communicate that when we communicate, an organization, healthcare professionals, and family work together, really and lasting change become possible. So we, what I can just say is just appreciation, but the journey, it has not just been an easy journey, but we thank the organization and the doctors, the way they came through, and we really appreciate. Thank you so much.
Thank you very much, Peter. Sorry for keeping you a bit longer than normal, but I just felt it was important to hear from the actual people on the ground, their parents, the ones who are going through this with their children. And we thank you for hanging in there. We thank you for sticking by Koban. And we thank you for believing in us, because you are the reason why we all exist. Without childhood cancer, unfortunately, we wouldn't have, the doctors, the nurses, the psychosocial support. We wouldn't have the civil society organizations. You are the reasons why we exist. So we appreciate you, and we'll continue doing what we can to continue to support you. Unfortunately, we don't have time for many questions.
Thank you.
But in terms of support, I have put our websites, both for Faraja Cancer Support Trust, for Hope for Cancer Kids, and for Hope and Courage International, into the chat box. If you need any support, kindly just reach out to us and we can see how best to support. But thank you very much again for joining us today. I'd like to thank Afron Oncology for Africa. I'd like to thank the Ministry of Health through the National Cancer Control Program. I'd like to thank the Kenyatta National Hospital, the Kenyan Network of Cancer Organizations. I'd like to thank Faraja. I'd like to thank our doctors, Dr. Rose Munge from KUTRH. I'd like to thank Dr. Doreen Mutua from Gertrude's Children's Research Hospital. And we continue to fight this together. The only way we can break those barriers, the only way we can ensure that the outcomes are improved, is if we work together. So thank you very much for joining us, and we hope to see you in the next webinar. Over to you, Nelson. Nelson, anything to say in closing? Feel free to leave at your own leisure. And as I said, thank you for joining us today. Have a good evening.